I am delighted to introduce our two speakers who will be talking about mapping the clinical and multi-omics terrain to new horizons in inflammatory bowel disease. A very new age fun topic. Our first speaker will be Dr. Kendall Beck. Dr. Beck is a renowned clinician educator with particular expertise in inflammatory bowel disease. She's the medical director of the ambulatory GI practice, where she works closely with the staff and colleagues in operational improvement initiatives designed to improve both the clinician and the patient experience. She earned her medical degree from McGovern Medical School at the University of Texas Health Science Center in Houston and completed her residency in internal medicine here and went on to do a fellowship in gastroenterology and has now been on faculty. She's also a member of the American Medical Association, the American Gastroenterologic Association, American College of Gastroenterology, American Society, oh my goodness. She's a member of a lot of fabulous medical societies around GI and Crohn's and colitis as well. Our second speaker will be Dr. Michael Kata. Dr. Kata is an MD, PhD, and an assistant professor and physician scientist in our division of gastroenterology here at UCSF. He specializes in treating patients with inflammatory bowel disease as well as immune checkpoint inhibitor-mediated colitis. So he obtained his PhD in immunology at Stanford and then came to UCSF for his GI fellowship, where he studied the role of intestinal epithelial cells in IBD pathogenesis. The Kata lab now focuses on developing precision medicine algorithms for managing IBD, as well as identifying less immunosuppressive regimens that actually improve epithelial survival and patient outcomes. So it is my pleasure to have them both speak to us today on inflammatory bowel disease and what is new on the horizon. Dr. Beck?
All right, thank you so much, Michelle. Dr. Kata and I are super excited to be here today to give you the updates in IBD. We'll start with clinical updates. We're going to talk about new therapeutics, combination biologics, and head-to-head trials, special populations, and some diet updates. I have no disclosures. So when I start to talk about IBD, I always like to talk about how our treatment goals have evolved over time and how that impacts prognosis and patients' quality of life. We know that achieving clinical response, which means improved symptoms, can lead to an improved quality of life for our patients, and that clinical remission, which means symptom resolution, can lead to reduction in hospitalization. We also know that achieving deep remission, by which we mean normal endoscopy and potentially even normal histology, can lead to surgery avoidance and minimal to no disability. So that's why achieving sustained deep remission is our goal for treating our patients with IBD. So to move on to new therapeutics, risankizumab is one of our newest biologics approved for the treatment of Crohn's disease. It inhibits interleukin-23, whereas its related drug ustekinumab inhibits both IL-12 and 23. Inhibition of interleukin-23 results in reduced Th17 expression of cytokines, which all promote mucosal inflammation. Risankizumab was approved in June of 2022 for Crohn's disease. It's given by IV induction every 4 weeks for 3 doses, and the maintenance is given subcutaneous every 8 weeks by a unique on-body injector. In the pivotal clinical trials for maintenance, clinical and endoscopic response was significantly better in the risankizumab group, including in those with prior failure of biologics. Placebo response was high in these trials, which is not uncommon in trials of biologics in IBD, but particularly in this group because many of the patients did receive drug in the induction trial and then were re-randomized to placebo for the maintenance trial. And the IV induction dose does have a relatively long efficacy. Upadacitinib is our new selective JAK inhibitor, which is approved in March of 2022 for ulcerative colitis, and then approved in May of 2023 for Crohn's disease. Due to risk of infectious side effects, as well as publicized risks of venous thromboembolism and cardiovascular events in the rheumatologic population with its related drug tofacitinib, the FDA label does reserve upadacitinib for those that have been intolerant to or failed anti-TNF therapy in the past, and does include a black box warning. It's also considered teratogenic at therapeutic doses in animal models. In the pivotal trial for upadacitinib, over half of patients did have pancolitis, and 73% had exposure to anti-TNF drugs. So this was a very kind of severe class of ulcerative colitis, and results demonstrated significant improvement in clinical and endoscopic response over placebo. It is relatively well tolerated, but does have some side effects of anemia, abnormal LFTs, and creatine kinase elevation. Yeah, Nader? In general, it means total placebo as the active treatment. Some patients are kind of on some of their other baseline treatments with kind of sometimes mild dose steroids, although usually patients have to taper off, or maybe like a mesalamine agent, but not any biologic therapy or any advanced therapy. So some very exciting data that was presented at this year's European Crohn's and Colitis Organization conference about upadacitinib showed that upadacitinib can promote fistula healing. So historically, infliximab has been our only drug that has demonstrated efficacy with fistula healing in the past. This data is from 3 of the phase 3 clinical trials that supported FDA approval. There were 143 patients in the group that had fistulas. 126 of those were perianal fistulas, and 19 were enterocutaneous fistulas. Their outcome was fistula activity, which they defined as presence of external opening and draining upon gentle compression. They also looked at the presence of perianal fissures. Figure 1 in green shows the patients achieving response at 12 weeks of induction, and including an impressive response in complete resolution of fistula draining, as well as greater than 50% resolution of draining on the right. Figure 2 in blue shows results of patients achieving response at 52 weeks of treatment. As is typically the case with most of our advanced therapies for IBD, the response did drop off over time, over the year. However, I think encouraging, it was still above placebo, and down at the bottom of the figure, complete resolution of perianal fissures remained high at 52 weeks, and overall clinical remission and endoscopic response also remained high over placebo in this group at 1 year of treatment. So we know from clinical trials that patients experienced improvement in stool frequency as well as bowel urgency as early as day 3 when starting JAK inhibitors such as tofacitinib and upadacitinib. And therefore, naturally, they're being studied as rescue therapies for acute severe ulcerative colitis. Acute severe UC is a GI medical emergency, typically necessitating admission to the hospital for evaluation, IV steroids, often starting a new therapy, and not infrequently requiring urgent surgical colectomy. Historically, infliximab and cyclosporin have been the only drugs demonstrating efficacy strong enough and rapid enough to be considered as use for this condition when patients aren't responding to IV steroids. So in this one study, a retrospective case control study with tofacitinib, 40 patients were treated and showed a reduction of colectomy at 90 days compared to no tofacitinib with a hazards ratio of 0.28. And they did show that only the 10 milligram 3 times a day dosing was protective versus the 10 milligrams twice a day that we use as kind of standard treatment in the outpatient setting. Complications and steroid dependence were similar between the two groups. In this case series, looking at 23 UC patients who received upadacitinib and had failed IV steroids, 81% were steroid-free or in steroid-free remission at 90 days, and 74% were actually colectomy-free at 90 days. There was only one venous thromboembolism in this group, and that was in a patient who was post-op from their surgical colectomy, and no post-op infections, herpes zoster, or opportunistic infections were identified. Two other new drugs in a completely different class of medications are sphingosine 1-phosphate inhibitors, ozanimod and etrasimod. Ozanimod was approved in May of 2021 for ulcerative colitis. It is an oral daily regimen, and approved for multiple sclerosis as well. It has shown only moderate efficacy and does require some dose titration as well as careful monitoring due to side effects of worsening hypertension, bradycardia, AV block, macular edema, and liver injury. So we tend not to go to this one due to the careful, close monitoring that's required. Patients cannot have had a recent myocardial infarction or cerebrovascular accident either before starting this. And then etrasimod was actually just approved this month, October of 2023, also for UC, also oral daily regimen, and doesn't require the dose titration, but has a similar efficacy and side effects and monitoring as ozanimod. So one of the more exciting developments within the IBD community are the anticipation of studies evaluating the use of combination or dual biologic therapies, as well as head-to-head clinical trials to determine the comparable efficacy of biologics against other biologics. There have been several kind of real-world case reports, case series, and even a small number of clinical trial studies reporting the outcomes of patients using 2 biologic therapies to treat their IBD. This is a systematic review and meta-analysis reported on the existing real-world data. The pooled number of patients in this analysis was 279. The majority were using dual biologic therapy for refractory IBD, and much fewer were using it for the treatment of just a separate condition that wasn't treated by their IBD medication, such as an extraintestinal manifestation or another concomitant autoimmune disease. The majority of the combinations used an anti-integrin, such as vedolizumab, or an interleukin drug such as ustekinumab as the backbone of this dual biologic treatment, as these are our 2 biologics with the safest side effect profile. Only 3% here in this group were reported to be using an anti-TNF plus a JAK inhibitor. In this group, there were 31% of patients that were experiencing some type of adverse event, with 7% of those of patients reporting a serious adverse event. There was an excellent clinical remission rate of 59%, which is comparable to some of our clinical trials with monotherapy for IBD, and certainly better even than some clinical trials who are enrolling these kind of refractory patients. And even endoscopic response was pretty good at 43%, and again, better than some of our clinical trials with monotherapy. Given this very severe refractory group that were likely headed to surgery, only 12% of them actually needed surgery in the end, which is really encouraging. And the first pharmaceutical-sponsored randomized clinical trial in both UC and Crohn's disease with dual biologics is underway, and they're investigating guselkumab and golimumab, which is an interleukin and an anti-TNF drug. So we'll be excited to see the results of that study. So prior to 2019, there were no head-to-head trials among biologic agents in IBD. Therefore, we had to rely on observational studies and imperfect comparisons between randomized clinical trials to inform our thought process about relative efficacy. Now, in 2023, we actually have 10 head-to-head trials underway and 3 of those that have already been published, which we'll talk about here. So the first study of a head-to-head biologic study that was published was the VARSITY trial, published in 2019. This looked at vedolizumab versus adalimumab in ulcerative colitis patients treated for 52 weeks. And at 52 weeks, they showed that vedolizumab was better than adalimumab for clinical remission and endoscopic response, though patients on adalimumab had a higher rate of steroid-free clinical remission. This was more prominent in the middle there for patients that had had no previous anti-TNF therapy as well. The second study of a head-to-head biologic trial was published in 2022, the CView study. This was ustekinumab versus adalimumab for Crohn's disease patients. All of these patients were biologic naive, so they had never been treated with a biologic before. They were treated for 56 weeks, and at the end of 56 weeks, they identified no significant difference in clinical or endoscopic endpoints, so concluded that these were relatively equivalent in the biologic naive Crohn's population. And then lastly, this is kind of hot off the presses, just presented this data this week at United European GI Week. the results of the sequence study, which looked at ustekinumab versus risankizumab. So this this study, looked at two interleukin therapies, looked at treating Crohn's disease. All of these patients had failed one or more anti-TNF, so they were biologic experienced, and they reported week 24 and week 48 outcomes. They found that risankizumab was non-inferior to ustekinumab for clinical remission at week 24, and they found that risankizumab was superior to ustekinumab for endoscopic remission at week 48, with 31.8% achieving endoscopic remission versus 16% in the ustekinumab group. So much work is underway in the research community to individualize treatment, and Dr. Kattah is going to talk a little bit more about that. We aren't quite there yet fully to individualize treatment choices, but there has been progress in providing evidence-based support and decision tools to providers in terms of care of particular patients that pose special challenges in the treatment of IBD. The first of those would be a pregnancy care pathway published by Dr. Uma Mahadevan and largely built upon her career's work of researching and caring for pregnant patients with IBD. This is a summary of the care pathway that was published. This supports GI and obstetric providers in caring for their pregnant patients with IBD from preconception stages, including management of contraception, fertility issues, and optimizing medical therapy prior to conception, all the way through their pregnancy as well as their delivery and postpartum period. So this care pathway delves into detail regarding each of these particular stages during the patient's reproductive period. Similarly, another group that tends to be underrepresented in clinical trials and our guidelines is the elderly population with IBD. About 1 out of 160 older patients are affected by IBD, and 15% of new IBD diagnoses are made in the older population. Recently, Gastroenterology published an expert review in their clinical practice series on the management of older patients with IBD. The update reviews issues of making the diagnosis of IBD in older patients, balancing management decisions with medical conditions frequently encountered in older patients, such as medical comorbidities, polypharmacy, reduced cognitive and functional status, and frailty. So we'll move on to diet updates. Diet is considered an important environmental factor in the pathogenesis of IBD, given its direct effects on the microbiome, metabolome, intestinal barrier function, and immune system. Beyond exclusively enteral nutrition for the induction of remission in children with Crohn's disease, a variety of specialized diets, such as the Mediterranean diet, specific carbohydrate diet, and the Crohn's disease exclusion diet, have been proposed for the management of IBD. I always like to think first about what is the evidence for diet impact on the development of IBD, and then how does it impact our course of IBD. So this study looked at the pro-inflammatory diet, which includes red meat, refined grains, and sugar-sweetened beverages, and they found an increased risk of Crohn's disease development in these patients. No increased risk in UC patients was found in this study, and in this particular study, they didn't see a difference with just consumption of sugar-sweetened beverages. However, this study published a couple years later looking at 121,000 patients did show a difference in patients who consumed sugar-sweetened beverages. These patients did not have IBD at study entry. They had a 10-year follow-up and did find an increased risk of Crohn's disease, but not UC in patients who drank kind of the highest amount of sugar-sweetened beverages. This study was one of the first that was able to show a large impact in diet choices on inflammatory activity in IBD. So this was 135 participants who underwent food diary and documented how much ultra-processed foods patients were taking in and expressed that as a % of caloric intake. They showed that increased episodes of active disease and fecal calprotectin elevation was impacted by patients who were kind of taking in the highest tertile of ultra-processed foods as part of their caloric intake in UC. They did not find an impact in Crohn's disease. So The data are kind of still out, still conflicting studies, but it does seem that diet certainly is impacting our IBD patients. What diet is optimal for patients with IBD that already have it, though? So unfortunately, there is a lack of high-quality data to guide diet recommendations in the management of IBD. A Cochrane review rated all the evidence as low or very low quality evidence for diet in the induction of remission for Crohn's disease. And our major societies in general lack guidance on diet therapy for IBD as well, with the exception of using or recommending exclusive enteral nutrition for pediatric Crohn's. We do know that the Mediterranean style diet pattern has been associated with lower inflammatory markers in first-degree relatives of Crohn's patients, and that the Mediterranean diet is associated with a lower risk of late onset Crohn's disease. However, many studies have shown low adherence to the Mediterranean diet, unfortunately, over time. One particular study was this one that looked at the specific carbohydrate diet against the Mediterranean diet in Crohn's patients. This study did not find any difference in terms of symptom remission versus inflammatory activity with fecal calprotectin or CRP in patients on either of these diets. However, authors concluded that the Mediterranean diet was simpler to follow and may have other health effects, and so they ended up recommending the Mediterranean diet for patients with Crohn's disease. Unfortunately, as we alluded to in the last slide, only about 40% of the patients were 100% adherent to the diet at week 12. And so what about diet as actual treatment for IBD, and why should we care about that? Why do we need that? This is a case that was seen in our IBD clinic of a young woman with refractory Crohn's, was desiring pregnancy, and unfortunately she had failed all FDA and even some non-FDA approved mechanisms at the time: thiopurines, infliximab, adalimumab, vedolizumab, ustekinumab, and upadacitinib. She'd failed all of these and was unfortunately not a surgical candidate. She did demonstrate evidence of active inflammatory disease with a fecal calprotectin of 1,000. And unfortunately, as we kind of saw in some of the other slides of our clinical trials, there does appear to be a ceiling on efficacy for IBD medications, and certainly worse for our biologic experienced patients. And so for her, we turned to the Crohn's disease exclusion diet. So this diet is a whole foods diet that is designed to kind of limit foods that alter the microbiome or intestinal barrier function and may be associated with reduction in inflammation in our Crohn's patients. It's typically combined with an enteral nutrition formula, so shakes like Kate Farms or Boost, for example, and includes 3 phases, 2 6-week induction periods, and also a maintenance phase. These phases are characterized by increasing food quantity and diversity and decreasing the formula throughout each phase. There have been several studies on this particular diet, but 2 that stand out. One was in the pediatrics Crohn's population, a randomized clinical trial of the exclusive enteral nutrition, by which we mean taking in only oral formulas, no regular food, versus this Crohn's disease exclusion diet and the partial enteral nutrition. And they found here that there was really no difference in the induction of remission of Crohn's in this population between patients who were doing exclusive enteral nutrition versus the Crohn's disease diet with partial nutrition or partial enteral nutrition. The one difference, though, was that patients who then were starting to transition from the exclusive enteral nutrition diet by adding foods did actually have more rebound inflammation than the patients on the Crohn's disease exclusion diet. And then the second study was, or looked at the adult Crohn's disease population. This is one of the first studies in the adult Crohn's population of a randomized clinical trial looking at a diet monotherapy for Crohn's. And I think the first looking at a diet monotherapy that actually used endoscopic remission as an outcome rather than just improvement in symptoms. They looked at the Crohn's disease exclusion diet alone versus with the added partial enteral nutrition. They found that overall, all patients, 63% of patients were in remission at week 6, and 50% were in clinical remission at week 24. And actually, 35% of these patients were in endoscopic remission at week 24. I should say these were mild to moderate Crohn's disease patients, so not severe refractory patients. And so they concluded that the partial enteral nutrition group did not show any kind of improved outcome over the just the Crohn's disease exclusion diet alone. And in fact, patients were more compliant when they did not have to take the enteral formula as well, so just eating the Crohn's disease exclusion diet. So for our patient, she actually did the Crohn's disease exclusion diet with partial enteral nutrition and dropped her fecal calprotectin, so her inflammatory activity, in half. And then at that point, they added risankizumab once it was approved, and her fecal calprotectin actually went down to completely normal after that. So just in summary, we have multiple new therapeutics available for our IBD patients, with new ones gaining approval annually, if not more frequently right now. Unfortunately, sustained remission is still not a universal experience for our patients, and there's much work to be done to kind of break that therapeutic glass ceiling. Part of this is being addressed by our head-to-head trials, or head-to-head clinical trials becoming a reality, and allowing providers and patients to make much more informed choices when choosing a therapy, along with studies on new modalities such as dual biologic therapy and diet. So I just want to thank Dr. Mahadevan, my mentors, Mahadevan and Dr. Turdeman here, and our UCSF IBD group, as well as our other GI colleagues, the trainees, and our clinical research coordinators who really run the show, and our excellent dietitian, Neha Shah, and all of our clinical staff.
Okay, great. That was a fantastic overview of the clinical updates in IBD. And so I spend most of my time in the lab, so it's always nice to make sure that I remember how to tie a tie. So, thank you for this invitation and for the chance to give some updates here. So just make sure I can. So I'll give some translational updates in inflammatory bowel disease and some updates on precision medicine in IBD using single cell and spatial multiomics, as well as some hypothesis testing using patient-derived intestinal organoids to study the role of epithelial cells in IBD pathogenesis. And here are my disclosures. So Dr. Beck just reviewed inflammatory bowel disease, and I think you got a sense from her presentation that we have a lot of medical options for patients now, which is really great. We have 4 classes of medications for moderate to severe Crohn's disease, 5 classes of medications for moderate to severe UC, and we're combining medications now. All of these classes work by different mechanisms, so lots of options for patients, but the question becomes, how do we choose the right therapy for each patient at the right time? And I think this case really highlights why we need precision medicine for IBD. This is a 41-year-old gentleman with Crohn's of the colon. He tried oral medications for several years, had some benefit with anti-TNF, but lost response, tried a second anti-TNF with methotrexate, had no response. Then we switched to anti-IL-12/23, and he soon failed that. And at this point, had really had years of suboptimal disease control and was intermittently on steroids. And you can see a picture of the colon down here on the left with multiple large ulcers and inflammation. Then we tried vedolizumab, which is anti-integrin therapy, and he achieved deep remission within a few months. And these are the pictures on the right here with no active inflammation. And so the question is, could we have predicted his anti-integrin response and maybe saved him a few years of ineffective treatment? And so one way to try and do this is to use multiomics to profile IBD. And so that's integrating genomics, transcriptomics, and proteomics. And these types of studies are highlighting pathogenic roles for stromal, epithelial, and immune compartments. And the goal of these approaches is really to understand the immune system of each patient in depth in order to identify the most effective and least toxic treatment for subsets of patients. And only few studies use simultaneous multiomics methods to look at the same patient samples to kind of enhance internal validity and really approaching each patient as an N of 1. And that's something that we're really working towards, as well as other groups. And so to do this, we set up the UCSF Digestive Diseases Biobank. And so at each patient encounter, we collect saliva, peripheral blood, and biopsies from multiple intestinal segments. And we collect multiple vials, all processed in different ways that are optimized for different downstream applications. And to identify patients, we use a Tableau dashboard that was developed by Dr. Uma Mahadevan in collaboration with the Data Core here at UCSF. And that has really proved invaluable because then we can anticipate when patients on specific therapy are coming in for their procedure. We can recruit them for studies, collect samples, and try and learn what we can. And then we couple that with clinical metadata and sophisticated biobanking, sample tracking, et cetera. And so these are the folks who are involved in this work. I just want to take a moment to acknowledge them. So this is work that's led by Elvira Manillo, who's a specialist in the lab, as well as Kathy and Julian, some former lab members. But we collaborate with all of the co-labs here at UCSF. So these are kind of, more than cores. They're really collaborative groups that focus on different applications. And so we work with all of them to do this type of work that I'm going to tell you about. And we also have some collaborators at the Chan Zuckerberg BioHub that assist with some informatics. And so, one thing you can do when you're trying to develop multi-omics approaches for precision medicine is to use case control studies. And this is an example of one study that we recently did looking at healthy controls, UC patients on different, biologics, and then a group of patients who are on vedolizumab, which is this anti-integrin therapy in inflammatory bowel disease. And we performed site-seq, which is single-cell RNA sequencing, coupled with 187 surface marker analysis on each cell in the biopsy and in the peripheral blood. We also do CyTOF, or mass cytometry, where we measure 37 surface markers on the surface of each cell in the biopsy in the peripheral blood. And then we perform spatial transcriptomics and proteomics on formalin-fixed paraffin-embedded tissue, or FFPE tissue, and I'll tell you about some of those methods. So just to give you a sense of what these data sets look like and how we can use them to gain new insights into existing therapies, this is what's called a UMAP. So if you're not familiar with this type of plot, basically each cell here is a dot, and the cells are clustered together by how transcriptionally similar they are, so they express similar genes. And then they're color-coded here by the type of cell. And we identified 51 cell subsets in the intestine. Prior to this, vedolizumab was really thought to primarily target lymphocytes, but we saw significant effects on myeloid dendritic cells, which is a different type of antigen-presenting cell. We saw very modest shifts in lymphocyte subsets, and we confirmed these changes with CyTOF, or mass cytometry. And so this just highlights how you can use these type of approaches that are unbiased to identify new cellular targets of existing therapies. And if you take a step back and look at the state of biomarkers for precision medicine and IBD, we have examples of genotype, measuring transcripts, protein levels, the microbiome, multi-omic signatures, and we really don't use any of these clinically. And so then when you ask, what are the barriers to using these clinically? Well, one barrier is that for most of these approaches, they require some type of specialized prospective sample collection, meaning you have to take a biopsy and put in RNA preservative or cryopreserve it in a special way. They're not hard to do, but they're just not routinely done for every patient. And so in that sense, it would be advantageous to take advantage of FFPE, or formalin-fixed paraffin-embedded tissue. So this is the default tissue processing for every sample that's collected in endoscopy and colonoscopy. We take a biopsy, we put in formalin, that gets embedded in paraffin, it gets sectioned on the slide, and the pathologist takes a look. And so if you can take advantage of these samples, you immediately have access to longitudinal samples that are archived for up to 10 years. And all the cells that you're interested in are there. And historically, there's been very limited information you can get out of an H&E stain. So, I have an example here of a biopsy from a healthy control patient versus a biopsy from a patient with ulcerative colitis. And we can describe the inflammatory infiltrate here, or look at the crypt architectural distortion, but that really has been insufficient for precision medicine, although that may be changing with some new machine learning algorithms that are coming out. And then typically, immunohistochemistry or RNA in situ hybridization have been limited to a few markers at a time and are very semi-quantitative usually. And so now there are methods to look at gene and protein signatures in FFPE biopsies with subcellular resolution. And that really has the potential to accelerate discovery, development, and validation of biomarkers. And so we use a variety of approaches to do this. For the purpose of this talk, I'm just going to focus on one of these methods, this CosMx 1000-plex spatial transcriptomics. And so this is an example, just a representative image of one field of view from one of these runs. And it's hard to see here, but each of these little dots is the measurement of one gene. And this is just showing a few genes, but we have information on up to 1,000. You can actually do up to 6,000 genes now per cell in a tissue section, and just showing an example here for some of the cell subsets. And so here are what the data look like in aggregate. So this run had 960 genes per cell. Again, each dot here is a cell. The cells are clustered together by their gene expression. And if you look at this green cluster, based on the genes they express, it looks like they'd be cells that be at the top of the intestinal crypts. And the blue cluster down here, they look like cells that be at the bottom where the intestinal stem cells are. And then you can basically look, click a button and look at the data and say, where were these cells? And you can see in the tissue that in fact the green cells were at the top of the intestinal crypt. The blue cells were at the crypt base and the orange cells are kind of in between. So nice validation of the approach. But then you can look at, activated fibroblasts. So fibroblasts with an activated signature or activated mononuclear phagocytes, MNPs, which are primarily macrophages. And you can see here they're color-coded yellow and blue that the density and abundance of these cells in ulcerative colitis seems to be higher than healthy controls. And so there's really a lot of information you can get out of these type of data. And so knowing that this works, we did a retrospective longitudinal spatial analysis of archived clinical FFPE samples. And so we pulled samples from pathology that were anywhere from 1 to 5 years old, looking before and after treatment with vedolizumab, just as kind of our first campaign looking at one therapy in particular. And we looked at responders and non-responders to this therapy in addition to healthy controls. And you can imagine that if you were trying to recruit these patients prospectively, it would take years, to really get non-responders, responders before and after therapy. But doing this approach where we just pull the samples that are already, sitting in pathology, basically, we could do this in a few months. And we make a tissue microarray where we take cores from the patient biopsies and we put them all on one slide. And then we measured 1,000 genes in each of the cells on this slide, as well as 64 proteins per cell. And then we compared at baseline, so before patients get vedolizumab, what's different between non-responders and responders? Because that's ultimately what you want to know for having some kind of score of whether someone's going to be likely to respond or not. And this is a heat map of expression Z-scores for each of these genes here on the right, the patients on the columns here. And these are sort of the non-response genes or the non-response signature here on the upper left, and then the response signature on the bottom right. Red is up, blue is down. And because this comes from spatial single-cell data, we could then look and see which cells are expressing these markers. This is a dot plot here where the size of the dot tells you the percent of cells that express that marker. And again, red is up, blue is down. And these genes that were associated with non-response to vedolizumab were expressed in activated fibroblasts and macrophages, whereas the response genes were expressed in epithelial cells, and in particular the crypt base where the intestinal stem cells are. And then we can go even further and look at where these cells and genes are in space. And so here on top, I have the, in green are basically the borders of each cell in the tissue. And then just an example of a healthy control. These two are pre-treatment vedolizumab responder and non-responder, and then post-treatment responder, non-responder. And if we look at the activated fibroblasts in yellow and activated macrophages in blue, we can see that they co-localize with these non-response genes. And so basically markers that are associated with activated macrophages and fibroblasts in the tissue of UC patients are associated with vedolizumab non-response. And then on the other side, the response signature was associated with a robust epithelial crypt base. And so when we look at those genes, we can see that they kind of co-localize with these epithelial crypts. And we validated these findings in an external bulk transcriptomic data set. And so, now it's really powerful that we have ways to look at gene signatures in tissue that already exists for all of these patients, on any therapies that we're interested in. And I think the next step is to look at additional therapies and then also see if we can predict prospectively who's going to respond to which therapy. And then in the interest of time, I'm going to skip over this just to say that we're using these approaches in a lot of different settings to look at other inflammatory disorders as part of a large consortium, to look at dietary interventions in UC, to look at immune checkpoint inhibitor-induced colitis, as well as pediatric onset IBD. And the last couple of minutes, I'm just going to tell you a little bit about the work on intestinal organoids, because I think there's a lot of enthusiasm in multiple diseases for using organoids. So just to summarize again, IBD is thought to be the result of an abnormal immune response to microbial stimuli in a genetically susceptible individual in the right environmental context, and that culminates in epithelial injury. And all of our medications basically suppress the immune system, which makes sense because it's an inflammatory disorder, but we have nothing as of now that targets the epithelial cells directly or the microbiome, and hopefully that'll change in the future. And our hope is that if we study intestinal epithelial cells, we might be able to identify non-immunosuppressive or less immunosuppressive approaches that kind of protect the epithelium. And that's one of the things that we're trying to use intestinal organoids to do. And so just some background on intestinal organoids. We basically, the way we grow these cells, we take biopsies from patients. The biopsies have crypts, intestinal crypts, and in those crypts are intestinal stem cells, and we embed those in an extracellular growth matrix in the lab and culture. We supplement them with growth factors, and they basically form these kind of three-dimensional miniature guts. And they can be grown indefinitely, they can be frozen and thawed, and they recapitulate many aspects of epithelial biology. And they also allow us to perturb living cells in vitro, which is a big advantage. And in terms of guiding therapy, so could you take organoids from a patient and sort of use it to choose a therapy? I think they're closest to the clinic for cystic fibrosis. It's probably the best example, as well as some examples in cancer. For IBD, the examples are less clear. I think the best one, or my favorite at least, is from this group at the University of Toronto, where they looked at a patient with very early onset IBD. So this is severe IBD that begins in infancy. This patient had a TTC7A mutation, had increased epithelial apoptosis and severe enterocolitis. And they did a drug screen and found that leflunomide rescued organoid death in vitro. And then they used leflunomide off label for this patient, which is something we would never do, in IBD with no other reason. And the patient improved clinically. And so just a really nice bench to bedside story of how you could use organoids to identify a rare disease, a way to treat a rare disease. There are examples, other examples stimulating organoids with inflammatory cytokines, and multiple ways to think about using organoids for precision medicine. Two examples, recent examples from our lab, I'll just mention that, we've used organoids from patients to reveal a role for lymphotoxin-induced death, which is kind of a cousin of TNF, and so that, may be an additional therapeutic target in IBD. And then we also did a study to look at this molecule GSK963, which is a RIPK1 inhibitor, which actually failed in phase 2 clinical trials for UC. But when we look at a group of organoids from non-IBD and IBD patients, we found that one patient exhibited less TNF-induced death in vitro in the presence of this compound. And so just kind of proof of concept of how you could use organoids to identify rare responders for a therapy that may not work for many patients, but there may be a few that do respond. And so it's just kind of a nice platform for testing ways to block inflammatory injury. There are also some companies now that have molecules in the pipeline that are trying to augment epithelial healing. So IL-22, Wnt surrogates, and I think organoids would be a really tractable approach to study responders to those types of therapies. And then the last thing I'll just mention is that they're difficult to grow for sure. There are some disadvantages. The growth factors are expensive. You're just really looking at epithelial cells, and the co-culture methods with other cell types are still evolving. But we're basically building a library from patients of intestinal organoids where we've sequenced the biopsies immediately upon sampling, as well as organoids that are grown in parallel. And that, we're hoping that kind of serves as a foundation to explore the epithelial contributions in IBD. So just to summarize, single cell and spatial multiomics are providing insights into specific therapies in IBD. Clinical FFPE samples are compatible with these emerging spatial multiomics methods, and I think will hopefully help us identify tissue signatures associated with response and non-response to each therapy. And intestinal organoids have unique potential to guide therapy. They're living cells. They're compatible with in vitro precision medicine assays. Significant challenges remain for working with them, but I provided some examples of how we can use them to study cytotoxicity and hopefully to identify less immunosuppressive approaches. And in the near future, I think these approaches and others could help us choose the best therapies for refractory patients. And so I'll just acknowledge the folks in the lab who did this work, all of our colleagues in GI who help with all these studies, the participating patients, the endoscopy nurses and staff, all of our collaborators and the sources of funding. And yeah, we're happy to take any questions. Thank you.
That was just fabulous. Great to get such a comprehensive picture from clinical to how we can apply omics to our clinical decision making. Terrific. Dr. Beck, I know, has to travel to the Hyatt to give a talk for our Dr. Wachters conference, so we'll ask her a question first and then let her go. So Dr. Beck, I was curious, I remember we had a patient with UC on our clinical service, and I was like digging through my file folder, and I found a PowerPoint from Dr. Turdeman. It was like this lovely stepwise thing, like 5-ASA and steroids and and biologics and surgery was at the end. And I'm just curious, from your perspective as a clinician, tell us what it looks like to have a patient with a new diagnosis and then go through all of these biologics. And I would love an update on, from an outpatient perspective, what that clinical course looks like and how all these biologics has really changed how you treat and think about disease remission.
Sure, thank you. So I would say that first of all, we're super lucky to have, we're kind of in a period of wealth with all of these different biologics. There also, I would say that kind of the pattern of step-up therapy, which used to be, I think, a little more common, has kind of transitioned into a, not quite a step-down therapy, but basically a treat the disease where it's at type therapy. So for someone with severe disease, you're not going to kind of do that step-up therapy any longer. And we have a lot of data that shows that patients who get into remission the fastest are the most likely to stay in remission and avoid surgery and all of the other complications that we see with IBD. And so there is data that shows giving anti-TNF or other biologics up front for patients that have severe disease, they have the best outcomes. That being said, I think that having all of these biologics at times, can be challenging, as kind of Dr. Kota was alluding to. Some patients you don't know necessarily, and I think we're getting there now with what we were talking about, but you don't know which drug patient is going to respond to. And so you kind of choose there are a lot of reasons why we choose something, either patient preference or comorbidities, et cetera. But sometimes we find ourselves kind of going through multiple biologics now when it's probably clear that the patient is going to go to surgery, but either unfortunately the poor patient doesn't want to have surgery, the doctor thinks we can try another drug. There's always a reason why someone ends up trying now 3, sometimes 4, 5 biologic treatments before moving to surgery. And so that can also be a little challenging, watching your patient sort of travel along the pattern for a while.
Enter Dr. Kota, who maybe has a potential answer for this in the future. I'm curious, I was struck that sometimes what we think is one disease is actually multiple different pathways that lead to the same clinical presentation. How has your research changed actually how you and others think about what we've commonly called UC or Crohn's as like 2 separate diseases? And yeah.
No, it's a great question, I think. And the anecdote that I presented is like a good example where, vedolizumab really is not particularly effective for Crohn's disease. This patient had Crohn's of the colon, and vedolizumab is more effective for UC, as Dr. Beck mentioned, and this patient seemed to respond very well to vedolizumab. So is he more like a UC kind of Crohn's than a Crohn's disease? And I think some of it is the intestinal location, so the colitis versus the terminal ileum being involved, in terms of differentiating response to various therapies. But I mean, at this point, it's really still all clinical. Like, we don't have any molecular tests that we really use to say this is more Crohn's or UC. Like, there are some kind of serologic tests that people do sometimes, but most of us don't use those because they're not particularly useful. So I think it's work in progress for sure. That's a good question.
And then maybe even within Crohn's, there's multiple different pathways.
For sure, Crohn's is very heterogeneous, and clinically you can define all the different subsets, whether it's stricturing, fistulizing, whether you see abscesses, et cetera. So I think having molecular signatures for all those patients will be really useful. Yeah.
Absolutely. Great. Well, we'll let Dr. Beck go. Go ahead. Don't want you driving down there and rushing. Thank you. A round of applause for Dr. Beck before she goes. And just wanted to invite any other questions from the audience. Yes, Dr. Jordan.
So Mike, the stuff on spatial multiomics, so now in retrospect, does it give you any insights into actually the old H&E analysis of the biopsies? I mean, because it seems like there in fact should be differences that can be recognized if you know what you're looking for, and maybe that would be faster to operationalize than doing these molecular.
Yeah, it's a great question. So what can we learn?
You could just summarize the question just in case.
Absolutely, yeah. So the question is basically, now are we able to, knowing what we know, can we look back at the H&E section and get information from the H&E stain, and that would be kind of a lower barrier to using clinically potentially because it's not so expensive, et cetera. And for sure, yes, in 2 ways. So one is to just make use of the H&E stain, and people are doing this where you just scan lots and lots of images and try and correlate that with outcome. The other way to do it, which is relatively new but I think really exciting, is to, when you have the corresponding multi-omics data and the H&E image, which we now have for a lot of samples, you can then look at a new H&E image and infer what the gene expression would be just from, still using AI and machine learning that, okay, this patient probably had this gene expression score, and you can kind of invent what the profile would be and then use that artificial, expression to kind of define who might be a responder or non-responder. And I think that would be really exciting to do. It's something that we're hoping to do, we haven't done yet. Yeah.
Yes, Dr. Najafi.
A quick question. The examples you gave of responders and non-responders of vedolizumab, knowing the mechanism of the drug, does the genes that you saw, is there a good plausibility story to why it would respond to some patient?
Yes, I mean, so yes and no. I would say that vedolizumab, it blocks alpha-4 beta-7 integrin, and so it inhibits leukocyte trafficking to the gut, and so we know that. And in terms of like the non-response genes, we saw more in resident cells, like the activated fibroblasts and some tissue-resident, innate immune populations like macrophages and other cell subsets that could be attracting inflammatory cells. Where if you block this integrin, they could still get into the tissue through kind of chemokine signaling pathways. So maybe, but a lot of the gene expression. This is one big drawback of the gene expression data, is that the gene expression for a lot of these molecules is really low. So if you wanted to look at like other integrins, it's just not good for that. And so I think there are some limitations of these approaches that I didn't get to go into, but yeah, it's a good question.
Dr. Kalua.
Hey, Mike, that was a great talk. Given that you sort of consistently find patient-specific markers and the potential that those markers now might be predictors of response and non-response, and given that for many disease areas, we get biopsies as a component of clinical care, whether we use old-fashioned ways of analyzing those biopsies or newer ways of analyzing those biopsies, how far are we from getting reimbursement for the work that you do, especially if it is relatively reliably predictive of something of clinical value? We've gotten there in cancer. Right. I mean, U500 now comes from stuff that was at this level 6 to 10 years ago, but is now prime time. Yeah. How close are we to prime time for some of this kind of stuff that you've gone over?
Yeah, that's a great question. I would say that it's still probably pretty far because the instrumentation that is used to look at these markers is pretty new, and I'm not sure there's an example of an FDA-approved test that uses these kind of barcoded probes, but it could be that one way to get around that would be to really narrow it down to as few genes as possible and as few proteins as possible, where it's just like IHC or RNA in situ hybridization, where there I think the barrier would be much lower, and so then it might not be so far off. Yeah, but no, it's a good question. Yeah.
Terrific. Well, we will end there. Thank you all for joining us in person and those who joined us virtually. And thank you to our presenters, Dr. Beck and Dr. Kata.
Thank you.